All right, guys, we are back working on chapter 36 this week. It is also a huge chapter. I'm dividing it into two parts as of right now, at least. That might change if I dive deeper into it. But the first half is pretty much going to be where we are talking about the differences anatomically between pediatrics and adults, also development of the pediatric patient in regards to age and what we should expect to find with certain age groups. And we're going to focus in on the assessment and what's different in our assessment versus what our normal assessment would have for adults. So here we go. We're going to dive in. Again, we're still working on special patient population. That's what pediatrics falls under. Typically, what we're dealing with when we're dealing with pediatrics, we're usually dealing with some sort of airway or lower airway obstruction, usually difficulty breathing. That's where you're going to find most, like if your pediatric patient is in cardiac arrest, it's usually not typically a heart problem. It's typically a breathing problem or an airway problem where you can't actually perform breathing. So that's typically what we're dealing with. We will get into some other emergencies, like I said, in the next segment, but this is what we're kind of looking on to focus on. We'll talk about all those things. One of the things we will need to be have a high index of suspicion for is reporting abuse. If mom and dad are giving you a story about how something happened or something's going on and it doesn't add up, like if they say their 10-month-old was trying to stand and was taking first steps, you need to kind of think in the back of your mind, like, yes, that is possible, but what is the likelihood of that? So, and they fell and they hit their head, or if the injuries just don't match up, that's when you need to start thinking about abuse. Again, there's different types of abuse. Neglect is one of them. The parent that just doesn't pay attention to the child, doesn't have any really regards for the child, is not there for the child. That's always serious too. We talk about homelessness and poverty. Those are things that is very real in our country for many populations. Trauma is big in the age ranges of 1 year old to age 44. That is the number one killer according to the CDC. Is trauma in that age range. That's a huge age range. Yes, pediatric patients can die of other complications such as maybe cancer, but trauma is the number one killer for a huge age range. One of the things that you need to be introduced with is that pediatric emergencies and pediatric calls account for very minute percentage of the call volume. We do not get pediatric calls. One is because mom and dad can just scoop the kid up and take him to the emergency room themselves instead of waiting on an ambulance. So that is one of the reasons why we don't have a lot of it. And two is the kids are pretty resilient. If they fall, get hurt, okay, they get back up and then they just live with the scrapes, bumps, and bruises. So, but with that being said, since we don't run those calls quite a bit, we do have a high anxiety as providers when those calls do arouse or do come. All right. One of the things that you need to be prepared for on a pediatric call is you're not just dealing with the child, you are dealing with the parent/parents/caregiver. You actually may have a couple of patients on scene. You may have mom and dad that are extremely anxious, feeling helpless, getting mad, getting pissed off and mad at you because they feel you're not working fast enough or you're not doing the right things, and they wonder what you're doing. How do you get your license? And they're just feeling helpless. So you may have that kind of commotion. What's going on? One thing that you can do is you can have the parent help in your treatment of the child. Even in a cardiac arrest situation, if the parent is remaining calm and can do it, chest compressions, anything, just here, hold this. Sit right by me, hold this. I need you to hold this. This is very important. Give them a job to do. If you feel that, or the parent feels that they're very involved in what's going on, they will feel that you as a provider are doing a much better job. To remove the parent and separate the parent and child it's bad for the child. It creates situational anxiety for the child, probably the same for the parent. And so if your first goal is to separate the parent and child and what's going on, that's not a good plan. Don't do that plan. But if you are looking to just go ahead and incorporate the parent as best of their abilities, that would be very helpful. Also, keep in mind, kids are not small adults. They're anatomically totally different, and we're going to talk about those differences. Again, I've already said that you're going to have multiple parents. The best thing you do is keep the parent calm, because that will keep and help keep the kid calm. Even if the parent is flying off the handle at you. We had a call the other day, 9-year-old fell off his bike, broke his leg, and we're in the back of the ambulance trying to start IVs. We've already secured the leg, and dad's flipping out in the back of the ambulance going, and it took us several attempts to get IV sticks, and he's just flipping out going, you guys stuck my kid 6-8 times, will wind up being 3 times. And sometimes, I'm not, like I just said, I'm going to kind of contradict myself what I just said, that you may have to pull the parent kind of away from what's going on, not separate them. The door, I pulled the parent away. The doors were still left open. I said, hey, listen, I understand you feel helpless right now. And that's really what it boils down to. Parents just feel helpless, and they would give anything to trade with their kids and be in their position and be the sick one or the injured one instead of them. And it's just pissing them off, and they're frustrated, and that's really what it's coming from. So most of the time, you should be able to keep the parent calm. And if you keep the parent calm, child's calm, everything goes a lot smoother. One of the things that you can do, especially with the younger children, is allow that child to be in the parent's lap. Don't create that situational anxiety or that social anxiety. So keep in mind, parents are key in this. And remember, this is their child that you're taking care of. So they're going to not be completely rational. And it's your job not only to take care of the sick or injured child, but to go ahead and keep the situation from escalating and become even worse. So you got to share your feelings. They may insult you. They may call you names and saying you're doing a bunch of stuff, but like you're going to have to find a way to be like, calm the parents. And you may need to have one special person on your team, or just you right quick, hey, listen, we're doing the best you can. I'm asking all the questions I need to ask. Just bear with me. So hopefully you will be able to thwart that situation. All right, we're going to talk about the infant. Now, your textbook decided to change definitions midstream. Apparently now infants start at 2 months or 0 to 2 months or whatever. That's not the case. With newborns, a couple days after birth. Neonates up to 28 to 30 days, and then infants all the way up to 1 year. So we're sticking with those definitions. But most of the time, the infant spends a lot of time sleeping, especially before age 6 months, sleeping, eating, going to the bathroom, wetting a diaper. That's pretty much its only function. But they should be able to be aroused. You should be able to pick them up and then open their eyes, look what's going on. You are going to have to cradle their head. If you're assessing an infant in this age range, 6 months or younger, or 1 month to 6 months, remember you're going to have to cradle their head. They want to basically be kept warm. They don't like being cold. They usually have a really good, vigorous cry. It's not kind of a flat tone cry. They get mad, but remember, crying baby has an open airway, and they should be breathing okay if they're crying. They should be consolable. You should be able to give them maybe a passy, or if you feed them with a bottle, they should be consolable. They shouldn't be agitated or mad. And as long as they're warm, dry, and fed, they should be okay. We kind of still talked about that already. 2 to 6 months, they say they're a little bit more actively social. They like to coo and babble a little bit. You can lay them flat on their backs; they'll move. They're usually always funny, and makes me giggle when they sit there and look at their hands, and their hands amaze them, and they grab one hand with another. So it's funny. It makes me tickled. Strong sucking reflex. They should be able to have the rooting reflex. If that's not there, that might be a problem. Again, the vigorous cry. Not really a lot of eye contact, but they do have facial recognition. 6 to 12 months, that's when they start being able to sit up and support themselves. They reach for objects, and let me just tell you that every kid, when they explore the world, they stick everything in their mouth. That's how they explore the world. I don't understand why. I'm not really privy to that information, but they literally take everything and stick it in their mouth. Anything you hand them will go straight in their mouth because that is how they explore the world. They do become more mobile. They start between these ages, between 6 and 12 months, they start crawling. They start actually trying to pull up, and some may even start taking steps or starting to master walking. Teething. They are teething. That's probably another reason why everything goes in their mouth, because putting pressure on those gums and trying to bite into things helps relieve some of that pain and pressure of teething. Teething is horrible. So just be careful what has been given to them. So, you might have a parent that gives them something that they shouldn't have gave them, and it may have been poisonous to a child or something of that nature, or a foreign body, and it gets lodged. That's how that's going to play in, as if the parent had gave it to them. So by age of 12 months, they should be learning the first words. Typically, it's usually mama, dada. And as you find they develop the third word, it's usually no, because it's probably one of the words they hear the most. Usually nah, no, no. So stuff like that. Again, don't create separation anxiety or social anxiety. And if they're persistently crying or they're persistently irritable, like a passy doesn't work, you can't console them by picking them up, or mom and dad can't console them by holding them, giving them a toy or their favorite toy, and they're just completely mad and upset, and they've got dry diapers and they appear to be warm, something might be wrong. So that might be why they're irritable. Could be they're tired. That's true, but that should clue you in that something's up. One of the things that we're going to use, and it falls under the general impression, as you're making your general impression, you don't have to touch the patient. You're looking at the patient. The Pediatric Assessment Triangle, also known as the PAT, that's where you're going to use and utilize your general impression, but you're going to kind of curtail it for pediatrics. And it has to do with appearance, work of breathing, and their circulation. But you don't have to really assess their circulation as far as the rate, rhythm, and quality of their heart rate. It's more of looking at their skin and how they actually look overall. And it does appear later, but I decided to put it up here too because I want you to see it. You want to know if they have a normal tone. Looking at a kid, the muscle tone is what you're looking at. Usually a child, especially one that's a little bit up on age, like 9 or 10 months, should be able to hold its head up. Mom's holding it on her, or mom or dad or someone's holding it. Usually it's on their hip. The baby should be able to support itself. Are they interactive? Do they look at you? Are they interacting in the environment? Are they tracking? Which means, do they see you come in, or are they looking at something and following its movements? Or are they noticing things that are suddenly moving in their area? Do their attention get drawn to it? Are they consolable? Can you make them so if they're upset and crying, can you get them to calm down? Giving them a passy, giving them a bottle, something of that nature. Do they have an abnormal look or a gaze as instead of any of that? So are they gazing off into space and not noticing you or not looking at you, or are they able to track you? Abnormal speech or cry. Are they talking within their normal vocabulary, or are they crying inconsolably? Do they have a weak cry where they just sound like they just gave out? That's the things you're looking for there in appearance. Work of breathing. Any abnormal sounds? Can you hear any abnormal sounds? Without having to do a respiratory assessment, get out your stethoscope and actually listen to the lung fields. Can you actually just hear anything as you're walking in? Are they in an abnormal position? Does it look like they're trying to put themselves in a position to help breathe better? Any retractions? I'll talk about what retractions are. Any nasal flaring, gasping, apnea? Are they not breathing? You look for that. We'll talk more about those also in our assessment. Circulation of skin. Can you look and see, are they pale? Do they have like mottled skin? Are they cyanotic? Those are the things you should be able to walk in, see, look, and just form a general impression using this pediatric assessment triangle. All right, so by age of 6 months, babies should be making eye contact. They should be able to kind of like, usually they see mom and dad. If mom and dad smiles, they usually will smile too. They could have lack of eye movement because they're developmentally delayed. That could be an issue. 12 months, again, they're foreign body aspiration because they're now getting to be more mobile. I promise you that if you dropped something up underneath the couch or somewhere up underneath somewhere and the baby is able to crawl around and you don't notice it, the baby will find it. It could be you dropped it 10 years ago and you still live in the same house and you clean every day and you do a great job. Just something obscure you dropped, baby will find it. So just that can happen. That's a true incident that can happen. One of the things you want to make sure your hands and stethoscope are warm because no babies like to be cold. If the child is quiet when you're examining a child, that's your time to listen. In the school-age children, we talk about it as we get on in our assessment, trying to actually do an assessment on a child. You will want to go, we usually go from head to toe in our assessments. Our assessment, we start at the head and we start at the head and work our way down. With kids, you're going to start from the feet and work your way up. Because that way they kind of realize that you're in your space, and then hopefully you kind of gain the trust from them that you're not really there to hurt them. You're just kind of touchy-feely listening, that kind of stuff. So that's what you're trying to do. You want to go from the toes to the head. It's kind of reverse order of what we're used to doing. But if they are quiet, that's a good chance to listen to their lung sounds, listen to their breathing, listen to their heart rate, stuff like that. You can also kind of use things maybe to kind of distract them, like jingling keys or a pen light. Just remember, though, they may reach out, grab it, and if you give it to them, it's probably going in their mouth. Toddlers. They say up to about 3 years of age. 3 years of age is when they're going to kick over and be a toddler. There's different literature. Some say 2 years old, some say 18 months, but up until the age of 3 is what we're considering a toddler, from 12 months to 3 years of age. There's different literature saying it's differently, but pretty much from the time that they start walking up until the time that they can go to preschool, that's considered a toddler age. Now, you might have more injuries in this group because these kids, I'm telling you, once they can pull up and start figuring out how to take several steps, they go from kind of stumbling, walking, taking a few steps to dead sprints everywhere. They're masters. I don't know how they do it, but it's crazy. They are experts and they master the art of dead sprint everywhere. So usually what happens is if they do get tripped up, they're going to trip up and fall. They will try to catch themselves, but you've got to remember too, for pediatric patients, their heads are proportionately bigger compared to ours to their body. So an adult, the head's proportionally kind of about the same, but in a pediatric patient, their heads are huge. And they're going to lead and fall with their head. They may try to catch themselves, but the head is still probably going to smack the ground. So keep that in mind. They're also fearless. They are fearless. They do not have the common sense yet to understand that things can be scary, but they are learning. They will start learning to fear certain things. They start imitating older behavior of their siblings or friends or parents. They can kind of understand like tummy and stuff like that if you point it to them. And also they don't fully chew their food, so that may cause aspiration. 18 to 24 months. The mind is developing. 2 years, they should have like a pretty solid vocabulary, so you should be able to kind of get some sort of conversation out of them if you go to talk to them. They should be able to name common objects. They understand cause and effect. They basically know that if they do this, something may happen. Usually it's when they do this, they get told no. So they may understand that, true. But their balance and gait should be improving, which means that they are still dead sprinting, but faster and with less fear because they're still fearless. Again, use your PAT. Keep the caregiver around. These are the age of children that you still want the caregiver around, and make sure that you involve this caregiver. Like I said, in all levels of involving parents, you should be able to involve the parents, but you probably need them for this still because they still have that separation anxiety. There's still aspiration risk. You're going to hear that throughout this whole entire thing. They're an aspiration risk. They're going to possibly choke. One of the things that you can do, especially with this age range, is that they're kind of curious about stuff, especially about new stuff. So before you do a procedure, like listen to their lung sounds, you can actually just listen to your own lung sounds And then you don't have to put the stethoscope in their ear, but you can give them the stethoscope part and let them pretend like they're listening to your lung sounds, show them that it doesn't hurt, gain their trust, and then turn around and say, let me do it to you. Can I do you? And they might be a little hesitant. Let me do you right quick. And then you listen to their lung sounds. So that you may have to kind of get a bit of level of involvement in there and kind of gain their trust. And it usually helps to let them do it to you first. And it doesn't help to have in the ambulance maybe a stuffed animal or some sort of toy that they can have. I know we carry a bunch of stuffed animals, probably about 5 or 10 of them in each ambulance that we have, and we give those out if needed. So that's always very helpful. Again, still involve mom. Let them sit in mom's lap. Give them a secure place. Let them feel like they have some sort of control somewhere, like they've got solid ground to work from, and you'll have to kind of work your way into gaining their trust. So there's nothing wrong with that. Be creative. That way you can, like I said before, be creative in that, and the fact that you're going to have to get things to gain their trust. That's basically what it all boils down to, is gaining their trust. But involve parents, and parents can really help. Like I said, involve them. Like, hey, listen, I need to lift her shirt right quick. Let me listen to her lung sounds and her heart tones, stuff like that. You can involve parents like, hey, listen, you feel her belly? Does it feel any different? Does it feel harder than it does? Mom and dad, they know how to distract their kids. They're pros at it. They know what can distract them right quick. Also, it may be kind of hard because the toddler might not want to sit still for the procedure. They might want to get down. They like to get down and run. They don't care that they fell, smack their head, and mom wants you to look at them. They're like, I feel fine. I'm wanting to run. So, and also if you're going to do any upsetting things, like maybe start an IV, do your assessment right quick. And then if you know you're going to do an IV, try to get that done out of the way so it's over. So that probably helps too. Preschool age, 3 to 6 years old. They understand directions like get in line, let's go here, do you need to use the bathroom, stuff like that. So, and they're able to describe sensations. They know that they need to go potty and stuff like that. They can identify where they're hurting. They can kind of point where they're hurting. And again, foreign body aspiration continues to be high at this age. You can kind of take advantage of the curiosity. It's kind of like before with the toddler and stuff like that. They may be curious about things, but these people, they're curious more along the reason of why. Why are we doing this? Why? And then you can just kind of break it down to, I need to listen to your lungs. I got to hear your breathing and stuff like that. So you got to kind of rationalize that. You don't have to rationalize. You just got to tell them, hey, this is why we're doing it. This is what we're doing. You're going to get this a lot. Respect child's modesty. Listen, they may feel uncomfortable with you, like lifting their shirt without asking for permission or having someone there to help them do that. So offer simple choices like, hey, listen, we got to really do this. Can I do this? Yes. Okay. And usually I use the okay at the end, like, hey, I said okay. And then like, okay. And then you can do that. So that kind of avoids the yes or no questions. Setting limits on behavioral, I'm not really sure what to tell you, but if you do have some behavioral problems, it may not fall to you to make happen, but maybe you can kind of help set the tone of like, hey, let's do this, okay? So, I don't know. If there's behavioral issues, the child's just not wanting to cooperate, you're probably going to have to incorporate parents or caregivers. School-age children. This is 6 to 12. This is a bigger range. A lot more development going on here. This is pretty much pre-pubescence, pre-puberty. So you've got children this is a huge range. There's a lot of development going on here. But really, they can start thinking in concrete terms. They ask very sensible questions, or respond to sensible questions too. They're not just asking why. They're asking, well, what about this? What about that? How does this work? And they want a little bit more detailed explanation and try to get a solid groundwork of how things. And they can take care of themselves. They can shower themselves. They can brush their teeth. All you have to do is like, hey, go make your lunch for school, stuff like that. And if you've already shown them how to do it, they've learned the steps to be able to repeat those steps. They can differentiate between emotional and physical pain. They know when they're just upset because their feelings are hurt, or if they're actually suffering from physical pain. So you might be able to have that help with that as well in your assessment. They can kind of tell you the cause of the pain and what may have happened. Obviously, if it's medically related and something's going on, they're not going to know what happened. But if they feel like, yeah, I was on the monkey bars, I fell and I hurt myself. They're starting to become kind of younger adults. So you need to kind of give them and speak to them with a little bit more respect. This is not an authoritative voice. You're not telling them you will do this and this is what's going to happen. You need to be like, hey, listen, this is what's going on. This is what I need to do. Here's why I need to do it. You need to give them a deeper rationale of the things that are happening. And also talk to them. Like I said, you treat them like adults. Obviously, you're going to have a lower end of adult conversation, but they're interested in things. They play sports. They do things. They make accomplishments. Talk to them about that, what they like, dislike, and things of that nature. Even if you don't understand what it is, have them explain it to you. That makes them feel great. They feel like they are teaching you something because today you showed up and they've never seen an EMS worker before, and you're teaching them something. So that can be very helpful as well. Adolescence. This is where you are now probably part of the enemy. 12 to 18, this is puberty. This is basically, they transcend from school age to adolescence when they start having secondary sex characteristics, usually growing pubescent hair, or they start having breast development, deepening of the voice, facial hair, underarm hair, stuff of that, hair around the genitals. That's where we start saying that they're adolescent. And typically, it does happen as early as 12, and it usually continues on through the age of 18 to 20 years old. This is where they're starting to find self-identity. This is where they're struggling to figure out who they are. They've always been part of the family and the routine, and they've done things that they've been asked to do, but now they're starting to figure out what they like and dislike and what they want to do with their lives and the direction that they feel that their lives should be going. So this is where they're going to start having to make their own choices for themselves, and they want to be treated like adults. Like the school-age children, you talk to them like adults, but you still kind of had the limits or the set boundaries. Here, they want to push those boundaries. They want to be their own entity. They want to think for themselves. So you need to kind of give them that respect. Say, hey, listen, this is what's going on. Like, really just cut it down to brass tacks. Listen, this is what's going on. This is what has to happen. We've got to do this, and this is what we're looking to do. And maybe let them feel like they're part of the decision-making, not really so much as like, this is what's going to happen. This is what we're going to do. We good? All right, fine, let's do it. More like, hey man, this is what we're going on. These are the decisions. We can do this or we can do that. Really, I suggest this. So really give them more choices. I already kind of talked about that. Most of this here. Really, the biggest fear in an adolescent patient is trauma, and it's usually disfigurement of some sort. One of the main goals in adolescence is it's kind of an oxymoron. They want to fit in, yet they want to be different. They want to be socially accepted for who they are, but yet they want to push the envelope of what they can get away with. They want to be part of the group, but they also want to be the forerunner and the person who inspires change, I guess, in a way of saying. So they're really worried about like cosmetic injuries, like if they've got, especially if they've got like a laceration in the face or a broke nose or something like that. Oh my God, what is everyone going to think? They're all going to point and laugh at me. Now I'm going to be different, and now I have to deal with that. So, keep that in mind. Tell them that, hey, listen, this is, you may have a scar, but hopefully, we'll get you a good plastic surgeon, or you'll get to the plastic surgeon. He'll be able to make this so it's very minimal. So, but be honest. Maintain patient modesty. And really, I feel that way with any adult patient too, especially when I got to do like a 12 lead and play stickers under a woman's left breast. You just be modest, maintain their modesty. Let them kind of set the boundaries. Like, hey, I need to touch you here, and let them know. Like, you should do that with every pediatric patient. But hey, listen, like part of the assessment, I got to touch you here. Are you comfortable with that? Ask if they're comfortable with it. If they're not, say, hey, listen, well, I need to do it because, and explain it to them. And then try to rationalize through it. So, if friends are on scene, friends are usually the social acceptance that they're looking for. So if friends are on scene, it may help ease some of their social anxiety. But at the same time, you've got to kind of use your best judgment. Do the friends really need to be in here? Maybe they can wait outside and let me do an exam on you right quick, and then you can talk to them. Kind of respect the adolescent's wish. All right, anatomy and physiology. So we kind of talked about the developmental differences in the overall growing up phases. Now we're going to talk about the anatomical and physiologic changes that may make it different, not difficult, but different for us being providers. So you should have a understanding that the child's airway, and we're going to talk about this. I've got a picture. Airway is smaller. There's different setbacks that you can have with it. I know the tongue is larger. The larynx is higher, trachea, and we've got tracheal tugging. I've got pictures, so let's just go to those. The tongue. The adult tongue is proportionally where it's supposed to be. The child's tongue is proportionally larger inside the oropharynx than the adult, meaning that the tongue is bigger proportionally to the actual body. So it could be in the way. The epiglottis, the actual flap that covers the glottic opening or the vocal cords when you swallow, in a child is floppier. It's more U-shaped instead of actually just sticking out and protruding, or also known as more omega-shaped, which means it's floppier, it's bigger, it's more in the way, which comes into play like if you're a paramedic and you're having to intubate this child. The vocal cords are further down and in. There's a different slant. They're at more of a awkward slant. Also, the narrowest point in an adult airway is the glottic opening. It is the vocal cords. But for a pediatric patient, that's not true. It actually cones and funnels down into the first several cricoid rings. That's the most narrowest part of it. So that's why you can use uncuffed intubation tubes there. There's less lung capacity. A child cannot hold as much air as an adult can. And we'll also talk about some tissue differences as well. Tracheal tugging, I know it's kind of hard to see. It's not actually the tugging or you pulling at your trachea, can't breathe. It's actually the trachea being sunken in due to the movements of you trying to breathe harder. So that should be one of the keys that to tip you off that the child is having some sort of respiratory distress. There's also some more. We'll talk about those as well. Infants and childs are more diaphragmatic breathers, meaning they use their diaphragms rather than their chest muscles more to create that negative pressure on inhalation. So if the abdomen has something on it and there's pressure, it will make breathing for the infant and the pediatric patient, the younger they are, obviously the worse it'll get, harder on that patient. The tissue of the lungs is more fragile. One of the things that we need to be careful of is we're going to talk about barotrauma, putting too much forceful pressure. But when you're like having to BVM or ventilate a kid, if you force and breathe hard on a kid, you can pop their lung. Also, the volume, the amount of volume you're putting in. You just want good chest rise on every patient. You're not looking to cram the whole bag in. You're not looking to squeeze every bit of that bag and getting it in. You just want good, adequate chest rise. So be careful for the volume because, again, you can damage and hurt the lungs. Compression injuries. In the event that you are doing CPR, compression on the chest, you can damage the organs considerably. That's why you have to use maybe one hand and just go 1/3 the depth of the chest. And I know that's kind of hard to gauge, but that's why they use the 1/3 instead of this many centimeters, this many inches, because obviously all people are different and the 1/3 for one child may be different for another. So that's why they use those. So maintain and think about that when you're actually having to do something. And this really falls in for CPR or ventilating the child. So just be very careful. You don't have to force the volume in and just want adequate chest rise, and you just want to be delicate. You want to be moving and you want to be working hard, but you don't want to be carrying that over into what you're doing, the end result or product of what you're trying to do. Part of the anatomy physiology of the rib cage. If you look, a pediatric or even a newborn, the rib cage starts out widened. It's widened. Whereas the rib cage in an adult is more narrow. There's a lot of organs that aren't covered now. There's a lot of abdominal organs that aren't covered. Also, the diaphragm spread out more, so it can't contract down as hard. Whereas our diaphragm, we can take a nice deep breath in and down, and the diaphragm will do that. But for the newborn, it's not going to be as forceful. So we've got to be careful of that too. The respiratory muscles, like the intercostal muscles, the diaphragm, they're not as developed. They say immature, but they're not as developed. So it means that they may fatigue quickly. That means they get tired. If they have to compensate and breathe and continue to use those underdeveloped muscles to breathe faster or to try to breathe harder, they're not developed. So what's going to happen is they'll get tired. With a child or a pediatric patient, the problem is they will actually maintain at a level, and they'll maintain, and then when they can't have it anymore, boom, drops out. Bottom drops out on them, and there you are with little to minimal warning of what's going on with a child. You think, okay, they're fine, they're doing okay. We gave them some oxygen, but they're not going to give you any real warning. They're just going to start becoming bradypneic, bradycardia, and that means they're circling the drain, they're crashing. Whereas an adult will gradually, progressively decline. There's also less functional residual capacity. What that means is, in their lungs, when they exhale, they have less volume than we have. Obviously, they're smaller. So if they don't have the reserves, or they don't have the dead space area that we have, so it's actually harder for them. They actually have the same oxygen demands we have, if not more than we have. So we'll get into that here in a minute. Some of the things that you need to look out for, as far as will tip you off that a child is working breathing, and why it's very important to expose the child's chest for difficulty in breathing. One is nasal flaring. When they try to breathe, their nares will open up, and their nose, they're trying to take in as much air as possible. You'll have sternal retractions. That means you'll notice that like the tracheal tugging and the sternal retraction, you'll see that looks like their neck is sinking down in over their sternum. Intercostal retractions, you'll see that basically it looks like their ribs are starting to poke out because their intercostal muscles are sucking in and squeezing in. And also they may have an anxious or tense face. That'll tell you too, like something's wrong. So basically that's how you're going to be able to tell that there is some serious respiratory distress. This is the respiratory rate for our pediatrics. I'm not saying memorize it, but you probably might want to memorize it just so you have it in case there's a quiz, or you have to match this on a quiz really quickly because you only get a minute a question. Just saying. When you're ventilating a child, one of the things that you need to do, remember I told you, pad the shoulders. Their head is proportionately larger than the rest of their body, especially in the occiput area. So what happens is this head gets rocked, and it's called hyperflexed. So their chin is literally touching their sternum. That will close the airway because the airway is very pliable. It's not got the strong cricoid rings in it like we have as adults. So if you pad underneath their shoulders just enough, you'll open it up just nice. You can risk something called hyperextension, where you basically take them into a too far of a sniffing position. Too much padding. That too, remember, it's still pliable. It's still going to close it off and make it harder for you to ventilate those children. So hyperflexion or hyperextension are bad. You have to find the Goldilocks version of just right. Also, keep your airway free of clear secretions. And use OPAs if they'll tolerate it. If you can use an OPA, remember the tongue is really big, so you want to keep the tongue out of there too. So if you can use an OPA, find a good padding, good sniffing position, and ventilate, not forcefully, adequately, with the right respiratory rate too. Like I said, I just show you the respiratory rate. It's not going to be 1 1000, 2 1000, 3 1000, 4 1000, 5 1000. Breathe. If it's a child that requires more oxygen, you might be doing it every 3 seconds. So you got to keep that in mind too. Again, the decreased oxygen reserves, because they don't have enough in their dead space, they do have an increased oxygen demand. They'll fatigue easier. You're just going to have a high index of suspicion and make sure that you're doing everything right. That's what makes this so hard with pediatrics, is because the fluctuation over time and their age and all the things that you need to know about them. So again, just make sure you got a good patent airway, pad it. Don't be forceful with your respirations. Get a good adequate chest rise and fall. You increase your rate if you have to. Make sure that way you get good oxygenation, and just keep all of that in mind. I know it's tough, especially when you're just now learning it, but those are the things you need to keep in mind. Cardiovascular system. One of the things that can tell you if a child's doing well is their heart rate. especially their resting heart rate. If you've got a pediatric that's asleep and their heart rate's 200, something's wrong. But you probably want to know these as well in case you have to match them on a quiz. Not saying you have to, but just saying. But keep in mind, so their blood volume, they have more blood volume, but circulating blood flow, the demands of the body, especially their metabolic demands. Remember, they're constantly growing. So they constantly need metabolic things, glucose, oxygen. They need cells that are reproducing and replicating and doing their job. So they need more oxygen. The only way that they can accommodate that is to breathe faster and pump the oxygen around quicker and offload the CO2 quicker. That's how they compensate. That is their compensation. And their compensatory mechanisms of being okay, we're okay, not okay anymore. That's how that works. Like I said, they do have larger circulating blood volume, but their blood volume per pound is much smaller. Let me repeat that. Yes, they have larger circulating blood volumes percentage-wise, but pound per pound, they do not have as much as they should. So, yes, it's probably confusing, but they do have the good circulating blood volume. It's probably larger than typically by adults, not volume-wise, but as a percentage whole, they probably have more. But they have still less volume than adult. So if they lose a little bit of blood, it's probably a big deal. Like I said, even in shock, I know we haven't really gone on shock trauma, but kids can maintain, and then crash and fall out. Not okay anymore. And that's what usually I refer to it. Okay, not okay. So that's how that works. So keep a high index of suspicion in trauma and respiratory distress. Intervene early. If you're thinking that there's a child in respiratory distress, put them on oxygen. Don't worry about it. Just put them on oxygen. It's fine. Like, I'd rather have you put them on oxygen and you maintain that child till you got them to the appropriate facility than, well, I withheld it and then they kind of started crashing and then I was trying to ventilate them and have it get worse when it didn't need to be. Bradycardia means that they are crashing, they are hypoxic, and you do need to manage aggressively, and I'm telling you, you won't have long on that. They'll be maintain, okay, not okay, and that bradycardia and the hypotension, if you can get a blood pressure on them and have the adequate size cuff to use, will tell you that, okay, not okay. So those are the things that you need to look for. If they start going bradycardia, like we talked about with our neonate resuscitation, just because they're bradycardic, doesn't mean that, they're pulseless, but here we are under 60 doing CPR, or under 100 we're ventilating, because we want to aggressively manage them before they get not okay. We use cap refill. If you really can't do a blood pressure, cap refill. We talk about it later on in our assessment, but I'm going to talk about it now too. I don't know. I know it may be kind of hard to see, but obviously the provider pressed on the looks like the infant's heel, and it should go away in 2 seconds. The whiteness of that, he basically pushed all the blood out of the capillaries, and it should fill back within less than 2 seconds. Anything that's over 2 seconds, that should be cause for concern. They do talk about the nervous systems. Really, they talk about the brain and spinal cord are not well protected, and because the vertebrae and the fontanelles in the head, which are the cranial bones, are still forming. So also their vasculature is more fragile. It doesn't have the good connective tissue that we have. So if they get bumped or banged, they may bruise a lot easier and they may bleed a lot more. So we have to pay attention to that. The brain requires more cerebral blood flow. So hypoxia, the risk for hypoxia is still even greater. Like, do not let your patient get hypoxic. If you put a pediatric patient on oxygen, no one will probably fault you. I won't. And if they have a problem, send them to me. Head injuries are greatly exacerbated by hypoxia. They say the spinal cord injuries are less common. I don't know why. Bones in children, musculoskeletal. The bones are softer and more porous than adults. That means they haven't calcified. The reason for that is because they're still growing. They've got to grow. They're not going to fill them in and make them solid until it's time. Also, you may want to consider that anything that might be a sprain or a strain to us may actually be a fracture, so still immobilize it. And we worry about the epiphyseal plates because those are the growth plates. Those are usually at the ends of the bones, end of the long bones. You want to make sure that the break is not there. If you have a break there, they need to definitely go see a specialist. And really, truly, you can have something called a green stick fracture. My oldest daughter had one. It's where basically, the reason why I call it a green stick is if you try to break a branch, especially a new forming branch off a tree, you can't really break it. You kind of have to rip it and tear at it, and it tears. But that's kind of the same thing. You kind of rip into it halfway, and then it kind of splits and tears as you're trying to like completely break the bone. So they may not feel that they actually have crepitus or a deformity showing, but they may still actually have a break. So you need a high index of suspicion for that as well. The fontanelles are big. The fontanelles can actually tell you a lot about a pediatric patient, especially when they're sick. So the fontanelles, obviously, let's go where the fontanelles are. They're the bones in the head that haven't quite formed where they suture together. So you have this area where it's just kind of like cartilaginous tissue. You could actually touch their brain, so be very careful. Like, you don't really want to mess with that. That's what it really looks like on an actual baby. To talk about the airway, I don't remember this. Padding and making sure under the occiput. Yes, we know that. But this can tell you the fontanelles. All right, so back to the fontanelles. The fontanelles can tell you a lot of information. If there is a head injury or there's bleeding or there's increased intracranial pressure, they'll bulge. It actually will bulge and stick out. Sunken in, they'll like actually sink in. They should be kind of nice and flat. You should be able to kind of see them. But if they're bulging, you've got increased intracranial pressure, possibly bleeding. Sunken in suggests dehydration. So you can kind of look at them and tell, like, look at that, sunken fontanelles, or, oh man, bulging fontanelles, probably got a head injury, something like that. Gastrointestinal, abdominal muscles. Like, remember we talked about the rib cage here a little bit ago, how it's wider and flatter and how the abdominal cavity is left more exposed. You can have more multiple injuries. The spleen is kind of protected in adults on the left side, the right side. The liver is kind of pretty well protected, but they don't have that protection. So they can actually have liver trauma and splenic trauma. It can happen. So, and it doesn't take a lot of force. Remember, they're still fragile. These are developing organs. And just a little bump may actually be catastrophic to them. So high index of suspicion when you're dealing with this kind of trauma area. And that's kind of like, see where the diaphragm is? It's way out into the side. So, it kind of follows the rib cage kind of falls out and it's widened. It's not like it's down and around. It's actually kind of out and widened. So now you have all this exposed, more exposed than would be in an adult. Integumentary system, the skin is actually kind of just thinner and it's more elastic. So it means it'll give, it'll move back to where it's supposed to go. The body surface area compared to how much they actually weigh is greater, meaning that they have more body surface area. So they actually can be, they can get colder faster. Heat will give off through the skin, and so they will get colder faster. Less subcutaneous, also known as fatty tissue. So that's not keeping them warm. Kind of the fatty tissue kind of helps keep warm, not there. So if they sweat a little bit and they kind of evaporate it off, they can get dehydrated a lot easier. They can get colder easier. And the severity to burns. Since it's thinner skinned, what normally would be like maybe a 1st degree scald to us might actually be a 2nd or 3rd degree burn to them because the skin is thinner. So a thinner layer for the burn to go through. So burns can be a lot more severe in these patients. Metabolic differences, they cannot store glycogen. Remember, glycogen is stored in the liver. Glucagon release the glycogen and it turns it into glucose, sugar for you to use. They need more sugar. Not saying you need to sugar these kids up. Some of these kids just do not need sugar, but they do have a higher metabolic rate. So especially going through all the changes, just growth and development all the way through puberty. What a high metabolic demand there is. So also that they lack the ability, musculoskeletal-wise, to shiver. Believe it or not, that's what shivering is. When you get cold, you shiver because you're trying to generate heat. That's kind of like when if you notice when you go and you do some sort of exercise or you get really warm, you get really hot from moving, that's because you generated heat through movement. That's what shivering's trying to do. Hypovolemia, electrolytes, if they get dehydrated, typically where you're going to find this hypovolemia, especially in the younger children, is nausea with vomiting and diarrhea. Vomiting and diarrhea means they can't keep anything down and they're having liquidy poops. So basically their fluid that they normally would have reabsorbed, especially in their colon, is not being reabsorbed. So, and trust me, it doesn't take much for a kid to become hypovolemic and dehydrated. So have a high index of suspicion if they've had diarrhea and nausea, even if for 12 hours, there's a good chance they might possibly be starting to tip the scale and be very dehydrated. So try to keep those children warm. All right, now our assessment. So we're going to talk about the changes. I'm not going to try to hit everything, but one of the things that they stress, have the age-appropriate equipment. Some services can't afford all that stuff, so just improvise and do the best that you can. I'm telling you, pulse ox and cap refill and your pediatric assessment triangle and heart rate and will tell you so much about a pediatric patient. Having their blood pressure, that's nice and dandy. Pulse ox is great for getting a heart rate. Use a cardiac monitor if you have to get a heart rate. You're not looking to use a cardiac monitor to interpret. You just want an adequate heart rate. So that can tell you a lot about a child. Let's see. Scene safety. All right, so do not get blinded. Do not be blinded. Don't put your blinders on trying to get to a pediatric call. For some reason, like we already know this call is going to make us anxious. We know we don't run a lot of these calls. And don't listen to the nature of calling, like, oh my God, we gotta go. And get there, like, where's the child? And stop paying attention to your surroundings, because there might be something in your surroundings that'll tip you off that this scene's not safe. So make sure you maintain your situational awareness at all times. Also, conflicting information. Again, we've kind of already touched on that for possible abuse. Use your pediatric assessment triangle as you're forming your general impression. Shouldn't take more than 15-30 seconds. Conduct your ABCDEs. We're going to talk about what those are. So we've got the pediatric assessment triangle. We're talking about appearance that use the Tickles mnemonic, which is the tone, interactive, consolability, look or gaze, speech or cry. We've kind of already touched on those. You're observing a child from a distance. Delay touching the child till you form your general impression, and make sure that you kind of gain the child's trust. You're kind of coming into the child's sphere, into their comfort zone, unless they're unresponsive. If they're unresponsive, get your pediatric assessment triangle as you form your general impression quickly, and let's go. Level of consciousness. This kid, if you look at this kid's got substernal retractions. That means underneath his sternum, it's getting sunk in and pulled in, probably from difficulty of breathing. And you look at his gaze. He's just gazing. He's staring off. His sole purpose in life right now is to keep himself alive by working on and concentrating on his breathing. And he's probably getting very fatigued and very tired, which means that he's going to crash soon. Your worker breathing, again, substernal retractions right there, in case you didn't get it the first time. Let's go back. Head bobbing, nasal flaring, we talked about that. Tachypnea, the high rate of that, but the head bobbing is where lifts his head, tilts his head back and forth, and inspiring. It's the child is getting tired. That's how you know. Cyanosis, we talked about, we know that, but acrocyanosis is where the hands and feet are blue. We talked about that when the child is born, the acrocyanosis on your APGAR scale, which we said was okay, but once it's been corrected, it's not okay to have it again. Maybe is that when they're young, yes, it is, as their cardiovascular system set up, so their foraminal valve closes. But for this, 2 months or older, that's not good. We don't want that. Nasal flaring. True cyanosis is in the mucosal membranes, usually around the lips, usually the nail beds, kind of around the sunken eyes a little bit. That'll kind of be a dehydration. Like I said, never wait to give oxygen. Don't wait for cyanosis. You're behind the ball at that point. You need to, if you feel like the child needs oxygen, go ahead and put them on a little oxygen. and then reassess, and keep reassessing. And if you need to turn it up and crank it up a little bit more, go ahead. Make a transport decision. You're assessing your ABCDEs. We're going to get into what those are. A is for airway. We already talked about positioning, differentiating between your medical or your trauma patient, your head tilt chin lift on your medical patients, and if you suspect trauma, do your jaw thrust maneuver. Breathing, calculate the rate. Probably want to do it over 10 or 15 seconds. That'll give you a good ballpark. If the rate seems inadequate for their age, you may have to assist ventilate them. Definitely put them on oxygen if you feel they need to be on oxygen. Listen for the noises, any audible sounds. Do a respiratory assessment if there's any audible sounds, and look to correct those if possible. Also look for the child to begin to fatigue. If they're getting tired, if they're just sitting there focusing on breathing, they're not looking around, they're not interactive, they're just focused on breathing, and then they start slowing, become bradycardia, that's okay, we're not okay. So just pay attention to that. Circulation, obviously control any active bleeding. You do want to see if you can get a pulse, rate, rhythm, and quality. Skin color will tell you a lot about it, what's going on. Cap refill time. Blood pressure is you've got to have, like I said, you've got to have the appropriate size cuff, otherwise it doesn't work. Different places where you can assess a pulse on a child. In your infants, you can do the femoral or the brachial, but as they get older, you can do carotid and probably radials as well. But carotids are probably going to give you a true bearing on whether they're strong or not, and then you can compare the two. Compare between the brachial and the carotid, or the radial and the carotid. Rate, rhythm, quality of the pulse. If they're weak, if they're strong in the core, weak in the extremities, if they're weak all over, and if they're thready, slow, weak, stuff like that. Capillary refill time should be less than 2 seconds. If it's not, then there are some perfusion issues going on. Just keep in mind, even in kids, even in adults, especially geriatrics, which was 65 or older, their hands might be cold. So keep that in mind, because that will give you a wrong SpO2 reading, or a wrong or incorrect capillary refill time reading. Disability, ABC, you got airway, breathing, circulation. D stands for disability, and we're not talking about disabled or handicap or anything like that. What we're talking about here is their level of consciousness on an APPU scale: alert, responsive to verbal, responsive to pain, or unresponsive. Check their pupils. Pupils will tell you quite a bit. See if they're dilated, if they're constricted, if they react to your pen light, those type of assessment findings. If you can use this, you kind of use this scale, or you can kind of judge it on their pain scale. Remember, pain is subjective. It's all in the eye of the beholder, or whoever is having the pain, how bad it is. So keep that in mind. But you can use that as far as basically you can either judge by the child's appearance, like how bad they're probably really hurting, or you might be able to, if they're old enough, let them point to the face. That makes it relate to them the most. So do that. Keep them warm. That's under exposure. Oh, exposure. Also, besides keeping them warm, expose the child. If you've got a difficulty in breathing, you might not see the substernal retractions, or the sternal retractions, or the intercostal retractions. You may see some nasal flaring and maybe see the tracheal tugging. Yeah, that'll clue you in, but they may not have all of that. And you go to expose their little chest, and there they are. They're having all those retractions, and you know that they're having a hard time breathing. This just got a whole lot more serious. Transport decision, based on your assessment, you're going to decide whether to load and go. Really, truly, transport decision, really the consideration here is where to take them. They don't need to go to an adult hospital if you can take them to a children's hospital. And even if you have to manage them for another 10 or 15 minutes extra, as long as they're stable enough and you can manage them adequately enough, you should be able to take them to a pediatric hospital instead of the adult hospital. I'm not really going to go over this because I still believe, regardless of your comfort level, you need to get comfortable. Transport time, that should be a little bit more taken into consideration of where to take them. Yeah, we're going to stay with that. They're talking about closest facility if it is urgent. If you are like in a cardiac arrest, then yeah, you're probably going to go to the closest appropriate facility. Especially like for us, Children's Hospital on a good day without traffic is 45 minutes away, whereas we have hospitals that are much closer. So if you're depending on how stable they are, if you just cannot keep them stable and they're going to crash, it is very eminent. You can go and bring them to an adult hospital, let them stabilize, and transfer from there. Car seats. Car seats are a big deal. A stable kid should not be riding in mom's lap. They should be in a car seat. There's only specific requirements where you should not be allowed or have them in the car seat. Other than that, they should be in a car seat. If you've got mobilized long bones or splinting, doesn't fit in the car seat, fine. If they're unstable and you're going to have to be pulling them, snatch them out of that car seat, then you should have just had them out of the car seat to start with. That's fine. And CPR. Other than that, they should be not in mom's lap. Now, I'm not saying that I have not done that before, but it has been under dire circumstances. But I understand that it is situational at times. But I'm telling you, as your instructor, car seat. History taking, the kid's probably not going to be the most accurate with history. Even when they are in the adolescent phase, they may not know their entire history because they're younger and just really don't remember. Allow children to cry. It's okay if they cry. It's up to you at this point to be emotionally stable and comforting. So comfort the child if they're upset, and don't tell them to stop crying or don't be afraid. And don't lie to them either. Tell them, I don't know, but we're going to try to do this. So, or I feel that this is the best option, or this is what we're doing to try to make sure that doesn't happen. Also, don't talk in medical jargon. Talk to them in English. I know we make you go through school and we make you learn all these terms, but really at the end of the day, you just need to be able to speak English to these people, especially kids. Investigate the chief complaint. Their drug use and other things. You cannot tell sexual activity. You cannot tell mom and dad. You cannot tell mom and dad. Now, you may have to put it in your report, and they go and come get your report and read it. That's not your fault. You have to report what you found. But especially in the adolescence, especially nearing adulthood, you may not want to have the parent around when questioning, asking if they're sexually active or if they've done drugs. They more than likely won't be honest with you, but at the same time, be like, hey, listen, I don't care. Send your parents away. I just need to know because I need to know just how I can treat you and what I can make things and how I can make things better or how to treat you or which direction to go in. And it would really help me if you tell me if you've done drugs or if you're pregnant. So keep that in mind. Sample history, do the best you can, especially if you only have just the child there. Secondary assessment, if they're not immediate, you can kind of go ahead and do your detailed physical assessment. If it's not an imminent life or death situation where you need to go urgently, but you can do a full body exam on them. Check everything for there. I mean, that should be pretty much on every patient, except for level of hydration is kind of new. For a pediatric patient is very, 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 very serious. Vital signs, good luck getting a blood pressure. Like I said, SpO2 if they're warm. That'd be very helpful. Heart rate, stuff like that. Let them express their pain level, or if you have to try to interpret their pain level. Normal rates. Remember, each patient's different. There is no real normal. They're trying to tell you how to assess. I say do the best you can with what you got. Reassess, obviously every 5, unstable, 15 if they are stable. Interventions, always do your interventions, reassess, communicate that to the receiving facility, and try to keep everybody calm. If you're calm, keep parent calm, keep kid calm. So you remember, you're going to have all of these people in and around these pediatric patients. And that's it. I'm looking forward to part 2. We'll see you guys then.